Welcome back, everyone. You are enjoying another episode of Fast Facts Pharmacology Edition, brought to you by a Tale 2 hygienist in partnership with Elevate Oral Care. And now, please welcome your host, Tom Viola.
Hi, I'm Tom Viola, a certified pharmacist, dental educator, and author. Stick with me, and I promise to make the next few minutes the best pharmacology learning experience you've ever had. Hi everyone, Tom Viola with Pharmacology Declassified with yet another Fast Facts Pharmacology Edition. Well, this one is all about osteoporosis, but we're going to break it up into 2 episodes because there's just so much to talk about. I've often told my students that if they decided to do a career change and didn't want to be a dentist or a hygienist anymore, one thing they could do is pool the resources together and come up with a drug for osteoporosis that doesn't cause nasty side effects. If you can come up with a drug to treat osteoporosis that doesn't cause nasty side effects, I've got 40 million people that want to take your drug. Well, what's wrong with the drugs we have to treat osteoporosis? Well, we've got some good ones, but they do have some nasty side effects. So let's go through the drugs that we use on a somewhat regular basis, or not at all anymore, to see where we've been and where we're going. Of course, the obvious choice in the treatment of osteoporosis would be estrogen, right? Estrogen replacement therapy. Why? Well, again, we said in an earlier episode that women have estrogen, which keeps their bones dense during their lifetime without having to carry around all that extra mass, muscle mass, right? But during menopause, when the production of estrogen wanes, now there's a real risk of osteoporosis because estrogen is not there to protect the bone anymore. Okay, so I guess we would use estrogen to treat osteoporosis. It makes sense, but giving estrogen as a drug increases the risk of cancers and thromboembolisms. So we don't want that. How about myocalcin? You might remember this drug, calcitonin. Well, calcitonin is a great hormone for producing thick bones. Why? It inhibits osteoclast and stimulates the osteoblasts. So why wouldn't we use calcitonin? Well, it just never really worked out very well as a nasal spray. Okay, well then maybe we need to start all over again and talk about a drug that's like estrogen but doesn't cause the risk of cancer. That'd be a drug like a SERM, a selective estrogen receptor modulator, also known as the drug Evista, raloxifene. Okay, well what does it do? Well, it mimics estrogen activity at estrogenic receptors on the bone. Well, it's perfect. Right, except it still causes the risk not of cancer necessarily, but the risk of thromboembolism. Still not batting 1,000 here. Definitely not. All right, well then how about teriparatide, Forteo? Forteo? That sounds like a really powerful drug. Well, Forteo, as a recombinant human parathyroid hormone, certainly seems like it would fit the bill because we use parathyroid hormone to make our bones dense. So why wouldn't we want to use recombinant DNA-produced parathyroid hormone? We would! Except it does such a good job, it could actually cause bone cancer. And we certainly don't want that. And finally, there's a drug called Prolia, denosumab, which is really a leap for us because it works directly on the osteoclast. It's a rank ligand inhibitor, so it actually interferes with osteoclastic activity. Well, that sounds wonderful. I guess we should use that, seeing the osteoclasts are the ones that tear down the bone and the osteoblasts are the ones that put it back. You could look at osteoporosis as an imbalance between the two, where you've got more osteoclastic function than osteoblastic function, so by all means, shut down the osteoclasts. Right. Except for bones that really require lots of turnover, lots of osteoclastic and osteoblastic activity, that's not such a good outcome. And that can lead to bone death. We're talking, of course, about osteonecrosis of the jaw bones and atypical femur fractures. Well, if I'm talking about osteonecrosis of the jaw bones and atypical femur fractures, wouldn't I be talking about bisphosphonates as well? Oh yes, my friends. But that's the subject of our next episode in Pharmacology Fast Facts. Until then, this is Tom Viola. Be well. Oh, and one more thing. If you want to hear more from me, be sure to follow me on Instagram, Facebook, or visit my website at www.tomviola.com.
Thank you for listening to another episode of Fast Facts Pharmacology Edition, brought to you in part by Elevate Oral Care, creators of the innovative and proven prevention-focused oral care products from Advantage Arrest Silver Diamine Fluoride to Fluoramax Sodium Fluoride Varnish. Learn more by visiting www.elevateoralcare.com and schedule your free CE staff meeting today. We'll see you next time for another Fast Fact.